Good afternoon, everyone. I think the time for food is over, and as a good conference should be, CME workshop should be, we should start on time, because unless we start on time, we cannot finish on time. And I thank you all for at the initial stage to joining for this Yatharthcon, the conference CME workshop, which would delve into POCUS and regional anesthesia. I just wanted to give a brief overview of why we planned this and how we planned this in this way. In the POCUS schedule, you can see that we have got some situation, some parts like spine also there. Usually in POCUS doesn't have a spine, but as most of us are anesthetists, I felt that it is necessary that you need to have an hang of how to do an ultrasound of spine and then go ahead. So we have included the spine. In the hands-on session in the POCUS, for each group, we have clubbed the ONSD, optic nerve sheath diameter, and the airway in the single. So one group will go to both the stations together. We'll divide the persons in the group, and we will, so they can swap in the same group only. We'll explain to you how it is done. I joined a year back, 31st August, I completed 1 year over here, and in this time we have done a lot of good works over here. The number of cases has gone up very high. Quality of cases has gone up. We have done all sort of robotic cases. We have done transplants are going on, robotic cases are going on. You have even started an observership program over here for anesthesia, which is related to regional anesthesia, POCUS, transplant, and robotic anesthesia. And we are planning also to start a fellowship very soon. So with these words, I thank all the delegates who have come from far off places like Gangtok. Then I have got from Pune, I have got from Bangalore, I have got from Dubai. So lot many people are coming from so far off. So it is our duty that you go back happy, satisfied, and the way you want the thing to be. So we'll start on time. And for the taking the thing forward, I will request Dr. Devyani, who will be the master of the ceremony, and she will manage the whole this CME workshop for the next today and the next 1.5 days. How the whole management would be by him. Thank you, Dr. Devyani, please.
Good afternoon, everybody. We are getting ready to start with the with today's session. To begin with, we have a session on optic nerve sheath diameter, measurement and implications. For this lecture, can I request Dr. Sumit Kalra, Consultant, Department of Anesthesiology, Perioperative Medicine and Pain, Sir Gangaram Hospital, to kindly start the proceedings.
Thank you, ma'am, for the introduction. At the outset, I would like to thank Team Yatharth and Dr. Anshuman for this opportunity. It's always a pleasure to be associated with your events. I bring greetings from Sir Gangaram Hospital, and my topic for the day is optic nerve sheath diameter. I'll be talking about the brief outline on why exactly we measure it. Since I only have 10 minutes, I'll just walk through the topic on a bit fast pace, and we'll be discussing on the final aspects at the workstations. So of all the Thank you. Of all the methods of non-invasive measurements of the ICP, ultrasound-guided ONSD measurement has a good correlation with the ICP. The advantages being it is a portability of the equipment, rapidly performed, it is a short learning curve, and low cost, avoids ionizing radiation, and avoids the patient transport for imaging. Brief anatomy review: the optic nerve is surrounded by a leptomeningeal sheath within which is contained subarachnoid space with CSF. The intraorbital subarachnoid space is in direct communication with the brain. My mouse is visible, then this is the communication, it is easily visible, and the anterior part of the optic nerve is surrounded, loosely attached, and is surrounded by orbital fat, and this area is most distensible, and various studies have proven that this is the area where we measure it. And the maximal sheet distension occurs 3 millimeter behind the papilla, and this is how it appears in the normal patient. And when the ICP is raised, the CSF goes in and this tubular structure becomes expanded like this, which is then picked up on the ultrasound. The subarachnoid space does not have a homogeneous structure, but it has complex arachnoid trabeculae and septa system, and it varies from patient to patient and within the sheath also in the same patient. The basics of ultrasound, this is the machines available at a hospital, and high frequency probe, low penetration probe is required for these measurements. Nerves or small part preset should be used. Some machines do come with the ocular preset too. A LARA principle of ultrasonic instrumentation is advised. Mechanical index, which is the relative potential of the ultrasound to create a non-thermal bioeffect, should be kept at less than 0.23. These are the figures seen on top of the machines at a corner. And thermal index, which is an indicator of a relative potential of tissue temperature rise, should be kept at 0. Ergonomics is very important for any USG examination. In this picture, you can see he's one of my senior, Dr. Bhuvan. He's doing a ultrasound scan of a patient of ICH who had come to us, and an EVD was done. And you can appreciate that the ergonomics that he's standing in at the head end of the table, and the operator, the scanning area, and the machine is in one line of vision, and he has both the probes to his disposal. There is minimal adequate lighting in the room, and he has achieved a reasonably decent image on the monitor. You can appreciate here with this scan. Tegoderm and jelly form an important part of the whole examination, and the various ocular views which are commonly done are the transverse view, which is the top view, the sagittal view, which is the middle one, and the inferior views. We'll be discussing about them at the workshop. I'll just skip through this slide because of the time brevity. So after adjusting all the parameters such as depth and time gain things, we achieve the best image quality. This is how we look at it. The vitreous is a hypoechoic structure. The optic nerve is seen as a longitudinal compact structure. This is the lens and this is the anterior chamber. This slide is just to put it to very, very basic level that why the optic nerve fiber is a hypoechoic layer, the pia mater is a hyperechoic layer, the subarachnoid space, water is black, so hypoechoic, and dura mater is hyperechoic. ONSD is measured, as I just told you, at 3 millimeter behind, and the mean of 3 measured values is taken. There is a short learning curve, and an experienced sonologist may take 10 to 25 examinations to get a grip over this method of examining. So the exact cutoff value has been a matter of debate. There have been numerous publications around it. So the range varies from 4.9 millimeter to 6.2 millimeter. Likely cause may be all the anatomical and measurement explanations, but they say that the trend is more important than one absolute value for ONSD measurement. There are various measurements which can be done now with ONSD, not just ONSD, but ONSD to eyeball transverse diameter ratio, ONSD including and excluding the dura, I and E, retinal artery Doppler, the difference between ONSD and optic nerve diameter. There is something new called as dimensions of arachnoid bulk ratio. We'll discuss in the next slide. And also deformability index, where AI has now played a role, and now it is calculated by semi-automation of processing of ONSD videos. This is a recent publication in which they have said that the DAB ratio, the dimensions of arachnoid bulk, is a more sensitive indicator than ONSD for this thing. But eventually, to calculate this ratio, you have to calculate ONSD only, as per the formula shown at the bottom. This is how we find the midline for the retinal artery, central retinal artery. You can appreciate, you just put a Doppler, and then you can appreciate that this is the papilla and the retinal artery is running through it. This is easily picked up, and then we can measure exactly at this point. There are a lot of limitations of this, like there's a lack of uniform cutoff value, it is operator dependent. There's a potential risk of pressure injury on the globe, false positive in certain ocular pathologies. Acoustic shadowing artifact may occur. There's a short learning curve, but it is still there. The best view is controversial. It does not give a yes and no for e-fast and POCUS like things. And the degree of uncertainty is inevitable as the measurements are happening at a millimeter level. I'll just quickly brush through now the various applications of ONSD across the spectrum of the patients we see. So for the applications in neurology, it has been shown to have a diagnostic accuracy of 100% for intracerebral hemorrhage. For SAH, it has been shown that there is persistence of the expansion of ONSD because of the impaired retraction ability of the optic nerve sheath after a massive ICP exposure. This is again a recent study which has shown why serial measurements are important for ONSD. And this is also a recent study which has again proven, it's a scoping review, which has proven that ONSD has a great test accuracy and has a strong linear correlation and is the most effective non-invasive method. It has been proven to be very effective in stroke, where it is useful in the early diagnosis of a MCS stroke complications and also the follow-up of thrombolytic therapies effectiveness. It has a role in idiopathic intracranial hypertension. I'm just rushing through because of the time brevity. There's an application for hydrocephalus to measure the outcome of surgery, to evaluate shunt malfunction. For intracranial hypotension, the PDPH, it has a significant decrease in ONSD when the patient changed the position from supine to upright, and even the response to treatment after epidural blood patch can be checked by ONSD. This is a recent article which has shown its efficacy in pediatric ICU as well. It has also been studied for patients with post-cardiac arrest and acute liver failure. For optic neuritis, the ONSD will be more on one side of the patient only, the affected side. It has also been studied in preeclampsia. This is recent two reports where they have uses for diagnosis of giant cell arteritis as well as for a migraine attack. Even for Press syndrome and meningitis, it has been evaluated. Intraoperatively, this is a recent study in which they have shown that the patient positioning and the pneumoperitoneum, as it is increased, the ONSD value increases, and the mechanisms that balance the increase in ICP becomes insufficient with time. It has also been evaluated in the post-op procedures where it has shown that it is associated with post-op cognitive decline. Effects have been studied beyond the OR in scuba divers also, where it has shown to have a higher optic nerve sheath diameter, the scuba divers. Similarly, they have been shown to have a lot of studies on ONSD are done in patients with acute mountain sickness, where ONSD increases with high altitude. But there have been debate that a single point assessment is questionable in such patients, so role is currently debatable. But the portability of these equipments have sparked the interest, and these machines have been proven, the portable ones have been proven to be very effective in measuring such ONSD values. People have taken these machines to even helicopters and ambulances to check ONSD, and they have been doing studies there also. AI has also penetrated to this aspect of the healthcare, and the automated image algorithm which they have made very effectively calculates ONSD. This is again a recent article in which they have shown that the average error which an AI algorithm reached in ONSD measurement is compatible with the human errors. A lot of work has been done now on the protocols to have the best image acquisition. So they want to sanitize how do you acquire the image. So this is a one closed protocol which was published, and now the Delphi protocol and further protocols are happening in the field of ONSD. I'll just conclude with this slide that the road ahead, the standards and techniques of image acquisition are almost a work in progress at this moment, but the further studies need to aim at ONSD based treatments as well as with standard treatments, and the future research depends on defining the threshold and the behavior of ONSD in increasing ICP in patients especially with traumatic brain injury and subarachnoid hemorrhage. This is a web search of the PubMed. When you search ONSD ultrasound, this is what you receive. Huge interest in the last decade in ONSD. So since invasive ICP monitor was introduced in 51, and it was eventually after 4 decades that it got incorporated in the Brain Trauma Foundation guidelines in 95. So ONSD has the same potential and is probably on the same path. So maybe in a decade or more, we'll see it is incorporated in the guidelines as well. Thank you for patient listening. Thank you. This is my family, work family at Gangaram. Thank you.
Thank you, sir, for that brilliant introduction and nice overview of the entire applications and the recent updates. For the next session, before we start the next session, I'd just like to give a reminder to the speakers. The session is for 10 minutes. At the end of 8 minutes, a bell will go on so that you know that you have to start concluding. For the next session on airway ultrasound, we have with us Dr. Nitin Hayaran, who's a professor in the Department of Anesthesiology and Pain Medicine from Lady Hardinge Medical College and Hospitals.
इसमें कर्सर नहीं इसके अंदर ये ठीक है छोड़ रहे
We'll be giving a buzzer after 2 minutes before the completion of the time. Suppose you have 10 minutes, so at 8 minutes you get a ringer, and then in 10 minutes you also get a buzzer. Thank you.
So thank you, Dr. Devyani. Good afternoon, everybody. So we will be discussing airway anatomy for this session, and I will be just giving you a brief overview of what all structures you can see through the airway anatomy and their clinical implications. So this airway anatomy is basically divided into upper and lower by the presence of hyoid bones, suprahyoid and the infrahyoid area. Suprahyoid areas basically consist of the oral cavity, and they are usually deep, so that is why we require a curvilinear probe for the suprahyoid deeper areas, as well as it has a longer footprint. So if you see this area from the mentum to the hyoid bone, it is a very long area, so that can be covered with a longer footprint. The superficial structures can be taken care with the help of a linear probe, and most of the scanning can be done with both transverse as well as the sagittal scanning. So parasagittal scanning is sometimes required when we go for the our superior laryngeal nerve block, as well as for the confirmation of the guide wire inside the trachea when we are doing a percutaneous tracheostomy. Positioning the patient is usually supine with patient in a neutral, rammed or a hyperextended position. So basically it has been divided into 5 basic views. Suprahyoid view, that is for the oral space assessment for any tumor, for any growth, or for the tongue thickness and the width of the tongue. Thyroid is for the epiglottis identification. For epiglottis identification, number 3 is the thyroid vocal cord functions. What are the vocal cord functions? Identification of cricothyroid membrane for marking, and suprasternal for the identification of your tracheal rings and the endotracheal tube conformation. Scanning, basically if you see this area is totally rough, you can see it is not a smooth area. So it is a bumpy area. You can see the thyroid cartilage and the cricoid makes it bumpy. So you need not to use a lot of pressure because it will be uncomfortable for the patient. You use ample of jelly, or there are certain things like you just keep a saline filled a glove or a transparent gel pad. So if you see this picture without gel pad and this is with gel pad, you can see the lateral images. You can't see the lateral image because of the air artifact. So that is the advantage of using this gel pad. So what is the clinical utility of this airway ultrasonography? Is the prediction of difficult laryngoscopy, assessment of OSA, evaluation of the airway pathology, localization of the CTM. Basically, when the CTM is your identification, your level 3, option C for your difficult airway management. So you have to identify CTM beforehand. Prediction of tube size, airway-related nerve blocks, real-time endotracheal intubation. I will just show you how to do this. Position of endotracheal tube, assessment of vocal cord function, especially after a thyroid surgery, and ultrasound guided percutaneous tracheostomy. So we will start with the suprahead. So suprahead, basically we keep the probe between the two mandible, and you see this area. So when we see from below, this is the skin, this is your mylohyoid muscle, belly of digastric, mylohyoid muscle, sorry, this is platysma, mylohyoid muscle, and geniohyoid, genioglossus and hyoglossus. So, but when you keep the probe, you will not see it like this, what we saw. It will be upside down picture. So from below, what we will see from inferior skin surface, the belly of digastric, mylohyoid is like a tent-shaped muscle, geniohyoid and genioglossus. Here, important thing is the lingual arteries. If you identify the two lingual arteries with the help of color Doppler, the distance between the two lingual arteries determine the width of the tongue, and it is an indication of your difficult intubation, laryngoscopy. Second is the sagittal view between the mentum and the hyoid bone. So usually we use a curvilinear probe. So this is the mandible and this is the hyoid bone. So here you need to identify the hyperechogenicity of air mucosal interface. So whenever there is a difference in the acoustic impedance, the structure will become bright, like bone, or there is a mucosa to air. So air mucosal interface is always a hyperechoic line. So here again we are seeing through between the mandible and the hyoid bone. This is the mandible, this is the hyoid bone. So you will be able to appreciate a bright hyperechoic line. So that may be the air mucosal interface on the top of the tongue, or it may be the palate. So if the tongue is touching the palate, you will be appreciating the palate. If it is not touching the palate, you will be appreciating the superior surface of the tongue. So you can ask the patient to have a sip of water so that you can actually appreciate the palate. So these are the dimensions that will be measured for the hyomental distance. So measurements can be done in neutral as well as extended position. These are the indices for the difficult airway, and the thickness of the tongue from the skin to the apex of the tongue. So these are the indices for difficult airway assessment. Then comes your hyoid bone. Hyoid bone is a bony structure. Then the thyroid membrane. So this is the thyroid membrane. So hyoid will be like a bone without any shadow beneath. Beneath that will be the thyroid membrane, through which we can appreciate the epiglottis. This is in the sagittal and this is in the transverse view. So this is the thyroid membrane, the pre-epiglottis space and the epiglottis. The cartilage usually is in the hypoechoic area, hypoechoic structure. Cartilage are usually hypoechoic. With age, they become calcified. So you will see when even the thyroid cartilage becomes calcified after a certain period of age. Below the thyroid membrane, you will appreciate the thyroid cartilage. The thyroid cartilage is an inverted V-shaped structure, and between it is the vocal cord. So how to identify the vocal cord? So one important thing is, this is also vocal cord and this is also vocal cord. So these are more hyperechoic and they are hypoechoic. So these are hypoechoic. So this is the true vocal cord and this is the false vocal cord. So the vocal, you will see when we will see in the scanning station how to differentiate between the true and the false vocal cord. And this is in the abduction and the adduction. So just appreciate this movement of the vocal cord. So you can appreciate it after you have extubated the patient in after a thyroid surgery also. So beneath the thyroid cartilage is the cricothyroid membrane. So in the sagittal section, you will see a hypoechoic thyroid cartilage, a hypoechoic cricoid cartilage. This is the air mucosal interface that is hyperechoic, and in between is the cricothyroid membrane. So this is the sagittal section. So in the transverse section, how to identify? So we have already seen the thyroid cartilage as an inverted V-shaped structure. So this is the thyroid cartilage as inverted V-shaped structure. Just beneath will be the cricothyroid membrane, and when we go further down, you will see a inverted U-shaped structure, that is the cricoid cartilage. So that is again come up, you will see the cricothyroid membrane, that is called Takat method. Beneath the cricoid cartilage, we have the string of pulse, like this is a T1, T2, T3 and T4, the rings, the tracheal rings. They appear as a string of pearls. In a cross section, you will be able to identify the thyroid cartilage, the tracheal rings, the thyroid gland and the esophagus. So this is the trachea with the reverberation artifact beneath the air mucosal interface, and mostly the esophagus has a bull-sized appearance on the left side of the trachea. So ET positioning you can directly by direct and by dynamic scanning on the anterior neck during intubation, or by lung scanning. Lung scanning will be dealt in a different lecture. So here what you can see is a double bubble sign in the transverse view, and in the parasietal view is a double track sign. This is without the endotracheal tube. You will have a reverberation artifact, as we already told. And when the tube is there, there will not be any reverberation artifact. There will be comet-tail artifact. So just this is trachea and this is esophagus. How to see the tube is going into the trachea or esophagus? So now the tube is into the esophagus. You will see two signs, double bubble. So there is trachea and this is the esophagus. Now it is going inside the trachea. You will see the reverberation inside the trachea. Superior laryngeal block, we will see in the scanning station how to identify this thyroid space for the last slide. The identification of the vascular structures for the PCT. Endotracheal tube size, we will see in the scanning station how to identify calculate the tube size. The lateral pharyngeal wall again can be identified for the determination of the OSA, risk of OSA. And these are the various markers that are used for the identification of difficult airway assessment. This is a DARAS protocol for the difficult airway assessment. And of these all, we have seen these three protocols that are measurement that are actually sensitive and similar specificity to the clinical measures. Thank you.
Thank you, sir. For the next session on gastric POCUS and EFAST, we have with us Dr. Chetan Mehra, Senior Consultant from the Department of Anesthesia and Critical Care, Apollo Indraprastha Hospitals.
A very good afternoon. So in the next 15 minutes, we'll go through the topic of gastric ultrasound and FAST. I bring greetings from Indraprastha Apollo Hospital. Now, why we do gastric ultrasound? It is mainly to assess when you are performing endotracheal intubation, whether electively or in an emergency situation, the patient has any risk of aspiration, where there is any content in the gastric antrum. If there is a solid content, then definitely the patient is a risk for aspiration. If there is a liquid content, then you can quantify how much liquid the patient's gastric antrum has, right? So why we choose gastric antrum? Because of its particular round shape and the property of gravitational emptying of its contents. And it accurately reflects the content of the entire stomach. The sensitivity of assessment of gastric ultrasound is highest for solid versus fluids or empty states. In which patient population are you going to do your gastric ultrasound? Obviously with the patients who are non-fasting, patients who are at risk of delayed gastric emptying like pregnancy, diabetes, CLD or CKD, patients in whom you have difficulty in communication or have altered sensorium which may not allow you to confirm the fasting status. Patients who have had any surgery, prior surgery for stomach, or have any alteration in the mechanics of gastric antrum, like gastric band in situ or previous fundoplication, may not be amenable to assessment by gastric ultrasound. Now for this procedure, patient will lie in supine position. You may have to flex the legs so as to relax the anterior abdominal wall. You will use a low frequency curved array probe with the settings in the abdominal preset. Patient lies supine, you place the probe in the mid epigastrium and you scan in the sagittal plane on either side, right? This is followed by change of the position in the right lateral decubitus position. By doing so, the content of the whole of the stomach, they enter into the gastric antrum and increases the sensitivity of the assessment. Now let us understand it again. So this is the body of stomach. This is the gastric antrum. This is the left lobe of liver, aorta with superior mesenteric artery. And this is the plane where you are going to assess for gastric antrum. Okay. Now in this picture, the left side of your screen represents the cranial end of the patient. The right side of the screen is the caudal end, and this is the anterior surface. What you see here is the vertebral column shadows in the depth. You see aorta, superior mesenteric artery. This is the celiac trunk, and this target-shaped empty structure is the gastric antrum. Now, in a patient who has antrum is empty, the stomach will appear as a 5-layered mucosal wall. By using the measurement tool, you can actually assess the circumference and the area of the stomach. As shown in this figure, the area is around 1.98 centimeters square. In the supine, when patient has had a liquid content, in the supine position, the antrum now suddenly increases. The sensitivity of this assessment increases when the patient is turned in right lateral decubitus position, and the area definitely increases from 16.6 to 20.24, right? The same can be done for solid contents. You can see that the first figure is in supine and the right figure in this RLD position. The circumference increases so much extent that the gastric antrum actually moves out of your scanning screen, okay? Now, what happens in solid versus late stage, whenever we are ingesting some food, we also ingest some air. So there's aerophagia. And we know that air is a poor conductor of ultrasound, right? So in the first stage, at the left side of the figure that you are seeing, this white color structure here, this is the air shadows, okay? So patient has had solid food and has also had aerophagia, so you cannot see anything beyond that. The whole structure is actual gastric antrum, but in the late stage, at the right side of the figure, you can see the air has moved out and the thing which remains is only solid content. This is a small video. You can see the liver. You can see the aorta pulsating in the depth, a superior mesenteric artery just above the aorta, and a target or bullet-shaped structure which is also showing some activity of peristalsis, that is the gastric antrum. So both can be seen here in supine versus RLD position. This patient has had some liquid content. In the right side position, the RLD position of the patient, the gastric antrum increases tremendously. Okay. This is a video showing the gastric antrum filled with solid contents. Okay. You can also see the peristalsis inside the gastric antrum. Okay. Now to summarize, once you have examined the gastric antrum, if patient has had solid food, he definitely has a risk for aspiration. Your examination ends here. You need not turn the patient in RLD position. Now if you have seen some liquid in supine position, now you want to quantify how much liquid it is. Now you turn the patient in right lateral decubitus position and do the measurement. If the volume is less than 1.5 ml per kg, so he has a less risk of aspiration. If the volume is more than 1.5 ml per kg, he carries a higher risk for aspiration. So all the measurements are done in right lateral decubitus position. Okay. We go to the next topic, which is FAST, that is the focus assessment with sonography in trauma. So we are talking about ultrasound examination of ultrasound in the settings of trauma. Okay. So what is the objective? You want to detect the presence of intraperitoneal, intrathoracic, or pericardial blood in the presence of trauma. Okay. The E-fast is the extended form of fast, where you also include examination for thoracic cavity for the presence of pneumothorax. The examination is based upon I-AIM principle. We'll go through this. First is I, which is indication. So what is the indication of doing this exercise? You want to examine the presence of free fluid, which is blood in the setting of trauma, in the pericardial cavity, peritoneal cavity, and thoracic cavity. How will you acquire image? You will need to use a curvilinear probe, which has a wire field of view and has a higher depth of penetration. A smaller field cardiac probe can be used for examining in between the ribs for thoracic examination. Okay. Now, to increase the sensitivity of your examination, if a patient has less amount of intraperitoneal fluid, you can give a head low position, Trendelenburg position, which will allow all the fluid to collect near the diaphragm, or you can give a head high position to allow all the fluid to collect in the pelvis, and then you can increase the sensitivity of your examination. Fast can be performed in a number of views. There is no fixed routine which you have to follow. If you feel that the pelvis is the source of trauma or collection of blood, you can start with pelvis. If you feel that liver is the potential source of trauma, you can start with the right upper quadrant. So you have right upper quadrant views, left upper quadrant views for spleen, pelvis views, and cardiac and lung views. We start with right upper quadrant view. In this view, the patient lies in supine position. You have to use a curvilinear or short footprint probe. The probe will lie in 8 to 10 intercostal space with orientation marker facing towards the patient's head. This is a normal right upper quadrant view. Here you see liver. The left side of the screen is cranial, right side of the screen is caudal. So you see liver, kidney, spine in the depth. You see this hepatorenal recess, diaphragm, thoracic cavity. Okay. And the hepatorenal recess, which is also called as a Morrison's pouch, carries the highest sensitivity of and specificity of collection of blood in the right upper quadrant, right? So this is a small video which shows a normal right upper quadrant view. Okay, you cannot see any collection of blood in the hepatorenal pouch. You do not see any collection of blood between diaphragm and the liver. Here this is a positive collection, positive intraperitoneal fluid collection in between the liver and kidney in the hepatorenal pouch. So you will say that your fast examination is positive in the right upper quadrant. Okay. Now if you extend your examination towards the thoracic cavity, you can also see a large anechoic shadow in the thoracic cavity. This in the setting of trauma will most likely be a hemothorax. Then comes the left upper quadrant examination. The probe, the difference between right and left is that the spleen lies more superiorly, more higher, and more posterior. So you have to skip one or two intercostal spaces higher, okay, and more posteriorly. In the normal left upper quadrant view, you will see, similar to your right upper quadrant, you will see spleen here, you will see kidney, you will see spine in the distance, you will see diaphragm, splenorenal recess. Now difference between the specificity of examination of right and left side is, on the right side, you have to first look at hepatorenal pouch, okay. Whereas on the left side, you have to look for collection between diaphragm and spleen, okay. So this is a normal left upper quadrant examination showing no collection of fluid. In the positive intraperitoneal collection, you can see the spleen surrounded by an anechoic shadow, which in the presence of trauma is most likely blood. It can be urine also, anything, right? Chyle also, but most likely we are looking for differential diagnosis of shock, okay? So we're talking of blood loss here. Now next comes the pelvis examination. In males, you will look for collection in the retrovesical pouch, and in the females in the rectovaginal pouch. Again, the patient will lie in this position. You may have to flex the patient's legs to relax the abdomen. Scan in the mid-sagittal and in the longitudinal plane and the horizontal plane. You will look for fluid collection under the bladder and on either side of the bladder and on the anterior surface of bladder. Okay, so depth of examination is going to increase here. Okay, that's how you manipulate the probe. This is a normal pelvis view. In the longitudinal examination, you see a urinary bladder which is filled with fluid, filled with urine. Okay, in case patient has a urinary bladder injury, bladder is going to be empty. You will not be able to do a fast examination using the pelvis views if the bladder is empty. We all have had ultrasound examinations. We all are given a bottle of water to drink before any pelvis examination. That is because the ultrasonographer wants your bladder to be filled up. That gives a good contrast to see beyond the bladder. Okay, so if patient has had a bladder injury, you will not be able to do a pelvis examination with regard to fast. Okay, so here you see a positive fast examination. You see the anechoic fluid under the surface of bladder and on the anterior surface of bladder. I hope you can appreciate that. Now we come to the cardiac views. Subxiphoid is the easiest to perform. What we want to look is, we want to look for the fluid collection in the pericardial cavity. You want to see whether the heart is beating or not, okay, whether the patient is living or not, okay. So this will be mostly covered in the fast station, so I'm not going to details here. Here you see a heart normally functioning in the subxiphoid view. This is a positive fast in the cardiac view, where you see the anechoic shadow between the pericardium and the cardiac chambers. The same can be examined using the parasternal long axis view. Here you have to understand that if the fluid is anterior to descending aorta, that means it is pericardial fluid. If it is posterior, it is the pleural fluid. Okay. Now we have finished image acquisition, indication. Then we moved on to acquisition. Third part is interpretation, right? So you've got all the examinations done, you assemble them, and you come to a conclusion whether the patient has a hemothorax, whether it is significant or insignificant hemothorax, whether the patient needs to go directly to the operation theatre, or you want to wait and do a serial examinations even after resuscitation. And yeah, last part of IAM is M, medical decision making. So this will help the medical physician to tailor his approach towards patient's management. E-fast is an extended portion of fast where you include lung as a component of fast. So you see normal lung sliding sign using a linear probe, and the absence of lung sliding will lead to diagnosis of pneumothorax. Then I think people will cover lung in their sessions. Thank you.
Thank you, sir. For the next session, the topic is focus for lungs. We have with us Dr. Munish Chauhan, who's a senior consultant in the Department of Critical Care Medicine from FMRI, Gurgaon.
Thank you, ma'am. Thank you for the introduction, and thank you, Anshuman, for the invitation here. So I am part of the critical care team at Fortis Hospital, Gurgaon, and it's been quite a long time now that we've been doing using ultrasound beyond the standard for vascular accesses and assessments. And in fact, it's become sort of a stethoscope for the intensivists today. And in fact, our first aid and all is part of the round that they have to do several times a day on almost all the patients. So I chose the topic which says that it's the lung artifacts on ultrasound, because the science is about artifacts. It's an optimal. It is not an optimal organ to be ultrasonographed because of a lot of issues. It has a lot of air, which is not a good conductor. Okay, less amount of fluid, more amount of air is there, and the principle of acoustic impedance and the transmission of the ultrasound waves from one plane of acoustic impedance to the other is what is the interplay is all about, and that is what we use when we do a day-to-day ultrasound. Most of the air is reflected back. The structures below the pleura in the air-filled lungs cannot be visualized, only artifacts can be seen, and this is what we build upon. How we see the artifacts, which as the name suggests are something which is unnecessary, how we view them, how they change, gives us a lot of information. Okay, so this is a real-time image generation that we see when we see the skin, the subcutaneous tissue, the ribs, and the pleura, and beyond that is an abyss. Okay, depends a lot what is the about the constitution of air. The normal lung has almost 98% of air. As this percentages of air goes down, depending on the disease condition, the images change and the findings change. Okay. Why we use ultrasound in the bedside? Well, several of us must have already pointed out, but that it has greater diagnostic accuracy. It is bedside, simple, no radiation, safe. Okay, can be several times a day. Yes, requires a lot of experience, a lot of hands-on training, but it has become more of a point of care investigation of choice for our intensivists, and you can see numbers pushing more than 90% sensitivity and specificity in the right hands. So quick, bedside, cheap, and safe for the patient. Generally, we use the curvilinear probe in the adults, especially. The certain microprobes are available, but not in most of our machines. So where do we see? Like if you remember in anesthesia, we were taught that you have to auscultate at the 5-point auscultations, the gastric, the lungs. So similarly, we have a 6-point auscultation in the lung ultrasound, and it was way back in 2016 that Lichtenstein gave the one of the first few articles and suggested these 6 points. The upper anterior point, what's also known as the upper blue point. Blue stands for bedside lung ultrasound examination. We have a blue protocols also. So we place our hand, the left hand below the clavicle, the index, the little finger. The thumbs are overlapping. Okay, and it is presumed that this index finger is at the level of the diaphragm. Okay, so midpoint, the base of the index and the middle finger is the upper blue or the upper anterior. This signifies the upper lobe. Okay, low anterior point is the mid palm of the right hand. This generally signifies the lower lobe, and then the flaps point. Okay, this is the posterolateral point. We draw a line horizontally backwards and downwards from the lower blue, where it intersects with the posterior axillary line. This is the posterior lateral point, and we see the flaps here, the posterolateral alveolar syndrome point. So this is the most dependent area where a lot of findings can be seen. These are 3 points which do it rapidly on both sides and get most of the findings here. Mostly the longitudinal scan is the positioning. This is how we place. Transverse scan generally done in very select cases. We go ahead mostly with the longitudinal scan and place it in between the two ribs. And this is what we get. Okay. Okay. So if we see, this is what we see. If I interplay it, superimpose the findings, this will be the subcutaneous fat region. This will not be mobile. This will be the muscle, again not mobile. There will be the rib shadows will be there. The ribs will show a post-acoustic shadow. So it will be dark, and this will be the pleura. Okay. The pleural shadows will be at regular intervals, repeated. This is the artifact. This is the A line that we say. Okay. At the same distance between the pleura and the immobile part, this will be at a regular. So this distance between this and this will be equal to this and this. If we see this, this is the normal lung. The presence of A line signifies that the lung mostly is normal. This is the first artifact, the A line. Okay. This is the reverberation artifact because of the reverberating waves in the normal lung. They are parallel to the pleural line. Regular intervals are equal to the distance between the skin and the pleural line. So this and this will be equivalent. Normal aerated lung or abnormal lung, which may be having the lung sliding and very predominant, that is asthma and COPD. So wherever the air component goes up, the A lines become prominent. These are artifacts because of the air. So in COPD, hyperinflated lungs, they will be there, but if the lung sliding is not there, then it will be a pneumothorax. Okay, we'll culminate it at the end, but this is how it goes around. So A line, prominent, mobile lung, COPD and COD can be suspected. No mobility in the lung, pneumothorax. Okay. So this you can see in the video. This will be how it will be moving around. So normal respiration, pleura, okay, A lines, equal to the distance there. The distance will be equal. This will be equal, and it will fade away. This is the post acoustic shadow behind the normal, behind the ribs and the lungs in between. Okay, and just run it again. So this is a normal lung sliding, lung movement going on, and this is the normal lung sliding. Some amount of fluid is always there, which can show certain shiny spots, sort of small B lines, but this is how it goes about. Okay, so this is the normal thing. And if you go in the M mode, in between the two ribs, this is the C and this is the sand, the seashore sign. The C is the area above the pleura which is not moving. That is the skin, the soft tissue, muscles, they are not moving. And the sand is the reverberation, the mobility artifact on the M mode. So this is the sea shore, the sea and sand sign. This is normal. That means the lungs have the normal proper movement. If the sea, the sand disappears from the sea, the stratosphere sign or the sea sign, the sand sign that we say, that means that there is loss of opposition between the pleura and the overlying skin soft tissue, and that is most commonly in pneumothorax. Not always, but there are other reasons of immobility. Maybe they are stuck together. Post-pleura disease, ARDS, lung pneumonia, they might be stuck together, or you have a single lung ventilation or a pneumonectomy. So this would be there in pneumothorax and infusion also there might happen. But one of the most dangerous and the urgent one that we need is a pneumothorax, and this is how it commonly presents. So with the normal lung out of the way, if you talk about interstitial syndrome, one of the most common is fluid overload in the lungs. It might be because of cardiac failure, CHF, or because of ALI-induced permeability. Okay, so the findings might be quite similar, and we see the famous B lines, which are just like the curly B lines we used to see on X-ray. So what is the typical of these lines? They start from the pleura, they cancel out all the A lines, they erase all the A lines and go to L as far as the probe goes. Okay, they will not start from above the pleura, from below the pleura, and they will move with the lung sliding. It will be like shimmering lines. Okay, vertical hyperechoic lines till the depth of the image. So on a still image, this will be how will they be there. They can still be normal, okay, but they are usually less than 3. A couple of lines is okay when one lung space, but more than 3 lungs, the signs B lines within one lung space is exhibitive of a excess amount of fluid, and they can be homogeneous in cardiac failure because there the fluid is homogeneously spread out. In ARDS, it is a non-homogeneous disease, so it will be more in some part of the lung. They might be lesser in some part of the lung. Sometimes they might become confluent. Okay, they might be such a lot amount of fluid in the lungs that they superimpose and become a confluent lines. There are a dissociation between septal B lines and ground glassing B lines. Most commonly we see this in cardiac failure. Septal B lines are more far apart, more close apart is the ground glassing, and this is a severe edema with the fusion of all the confluent lines. Totally white lung. So this is generally how we see it. If they are far apart, this is an acute. They are closely placed. This usually is pulmonary edema. In interstitial fibrosis, in ILDs, you can still see them, but they will be far apart because it's only in the septa, not in the interstitium. Normally, also 2 B lines per spaces, not 3 or more, is what is pathognomic of a interstitial syndrome. You can differentiate between a cardiogenic cause of pulmonary edema and a non-cardiogenic cause by whether the lung sliding is present or absent. It will be mostly absent in ARDS and pneumonia. It will be irregular in pneumonia. We'll see in the later part of the lecture when pneumonia presents, the pleura becomes irregular, but it will be smooth in the cardiac one. It will be homogeneous in cardiac. In X-ray also we see it's homogeneously spread out fluid. Okay, but pneumonia will be in one side more and less on the other side, so it will be areas of sparing absent B lines and areas of prominent B lines in pneumonia and ALI. Consolidation obviously will be in ARDS. Lung pulse will be present in ARDS because lung pulse requires solid tissue, which is more in ARDS because of the pneumonia setting in. And pleural effusion most of the time is there in cardiogenic. So this is how we differentiate what is the cause of in the interstitial syndrome. As discussed here, lung pulse is the transmission of the cardiac pulse, and transmission will be better through a solid organ, which is a pneumolytic lung, and lesser through a non-solid aerated lung, which might be CHF or a pneumothorax. And the M mode, you will see a disturbance at regular intervals, which will overlap with your heartbeat. So you can see, to differentiate from other causes, you can see that this is occurring with the heartbeat, and this will give you a sign that yes, this is a lung pulse. Why is it important? Because it is part of the flow chart when you diagnose pneumothorax. Okay. So just the absence of the lung sliding doesn't tell you it's a pneumothorax. There can be n number of other causes, that is I told you in the previous slide. But if it is present, then the pneumothorax is ruled out. So you have to look for other causes. But if it's not there and the B lines are present, again pneumothorax is ruled out because the lung is still there, it's moving. Okay. If the B lines are also not there, then you see the lung point. Lung point, I'll see in the next video, is the point between the normal lung and the pneumothoracic lung. Okay, where the pneumothorax ends and the normal lung starts. Depending on the size of the pneumothorax, if in a lying dying patient, the air will come anteriorly. So my pneumothorax might end here, but after 1 hour it might expand. So depending on the expanding pneumothorax, the point between the where pneumothorax ends and the normal lung pleura starts, that is the lung point. If you see it, it is diagnostic of pneumothorax, because obviously you are seeing a normal and a abnormal lung side by side. Okay, but if you don't see it and you don't see the lung pulse also, then it's a pneumothorax, because there is no tissue between the pleura and the lung. There is air, so the lung pulse will stop there, it won't go over. But in a normal lung or a pneumolytic lung, it will go over there. Okay, so with no lung sliding, with no B lines, with a lung point and no lung pulse, it's pneumothorax. Okay, and A lines, as I said, will be present, most likely will be present because air is there. A line requires air. Okay, this is the stratospheric sign. So you can see this movement is just a side by side. It's not a lung sliding. It's in and out. It is because of the air going into the rest of the lung. But there is no side by side typical lung sliding movement, and there is no seashore sign. Okay, this will be the lung sliding. You can see beautifully here. This lung sliding is present. Sorry, this is the lung point. This is the movement of the normal pleura, and it's not moving here. And if you at the same point you check for the M mode, the normal lung going to the the point will vary as the pneumothorax will expand. It will go outwards. Okay, depending on the position, lying down patient or a sitting patient. Subcutaneous emphysema also shows an artifact, which is the E line. Okay, this is the emphysema line. The only difference with the B line is that it starts from the tissue. If you remember, the B line starts from the pleura. Okay, this will start from the right from the probe end. You can feel the capitus also, and it will go to the edge of the spleen right downwards, quite similar to the B lines. Then the last two syndromes that we are talking about are alveolar syndromes and the atelectic syndromes. Here the amount of air is very less, there is a lot of fluid, and mostly it is consolidation or atelectasis that present like this. Okay, so consolidation will be irregular. You will know when you see it. Okay, if you have been seeing the images, it was so smooth, the lungs is like this. Now here you see an irregularity. Okay, which is some bright areas, hyperechoic areas, hypoechoic areas, something that's bitten off from the lung. Okay, and you will be B lines and fluid all around it. Okay, you can see some consolidation. So this will be present, and beyond that the echoes won't go. Another sign you will see typically in alveolar syndrome will be the tissue sign. You see the lung lying over the liver. Okay, it will be highly fluid filled. You can see these spots. Okay, which show that this is consolidation. Okay, and there might be some fluid around it. So this will be a tissue like sign. It's waving like a tissue. It will be like this. The lung will be floating like a tissue in this thing. And because there is no air, your ultrasound waves might travel even to the opposite pleura, because it's a good conductor. There's no air, there's fluid. So you can see a very clear image of the liver. Even the IVC will be seen from right here, because it's now the waves are traveling far and are being reflected back. Okay. Another one is a shed sign. You can see it's been shredded. the normal pleura is just totally shredded out. Okay, like a chunk has been bitten out. Okay, there will be some sliding, there will be B lines, irregular inhomogeneous B lines, and the lung margins will not be sharp. So this is another marker of consolidation that you can see. Okay. You can even, to the trained eye, you can see air bronchograms also. Fluid or air bronchograms, air obviously will be white, while fluid bronchograms will be black, because it will let the waves pass through. The air bronchogram will reflect back the waves, so they will be bright. You can see these. Okay. The air bronchograms, we divide them into, this is similar to the bronchogram that we see on the CT scan. Okay. We divided them into dynamic and static air bronchograms, and dynamic air bronchograms will be there in pneumonia. Atelectasis will have static air bronchograms. So you'll see that they'll be moving around. Okay. They'll be dynamic. Look, you can see they are dynamic. So this is pneumothorax. If there is no movement, if there is movement, then you can say that bronchial obstruction or collapse is not there. Okay. So you can differentiate between a collapse also. They are bronchograms, they are moving around, that means at least air is going. Okay. Otherwise, atelectasis can be the commonest diagnosis. So you can see static air bronchograms will not move with respiration. There is a lung floating here. This is the diaphragm. This is at the angle. This is the lower flaps. Okay. And there will be an effusion around. So this will be a tissue sign. Lung pulse will be present because it's a good conductor now. It's a solid organ. It has almost looks like a liver. So it will conduct the pulse through and through. Okay. You can also locate the diaphragm just lying above the liver. This is the lung. This is a lot of effusion. This is the diaphragm between the lung and the liver, and even the IVC can be seen through a transhepatic approach. Coming to the last part, pleural effusion, one of the commonest diagnoses and intervention. This is more of a not only a diagnostic but an interventional procedure also, and this approaches almost 100% sensitivity and specificity. You can also sometimes differentiate between a transudate and an exudate. There will be a lot of echogenic margins. There will be floating echos. There will be partitions in between. Most of the patients in the ICU are lying down, so they are posteriorly and caudally present, and they can sometimes spread out in the posterior margin, and the lungs, depending on what is the degree of effusion, it will float. So if there is no diaphragm in the view, you are higher up, okay, you will see the cord sign. Okay. You will see the fluid lying in between the rib and the pleura. This will be the pleura and this will be the rib. This will be the rib, okay, and this will be the parietal and the visceral pleura. The parietal and the visceral pleura. So you are seeing cutting from the side. You are seeing from this view. So when you see between the two ribs, you will see this is the caudal, this is the cephalid rib, this will be the caudal rib, this will be the viscera at the top, the parietal one, and the pleura at the parietal pleura at the top, and the visceral pleura at the bottom, and there is fluid in between. You can see the B lines also because of the most likely pneumonia present, or this more likely seems to be a CHF. Okay. You do a color Doppler, you see the fluid moving around, so you know this is a pleural effusion. If you bring the diaphragm into the picture, okay, so sorry, is this a video? Now this is the cord sign only, and this, sorry. Okay. If you bring the diaphragm into the picture, you can see the free floating lung and a lot of fusion with the tissue sign and the shed sign. Exudates, you will see floating margins, echoic effusions, okay, a lot of septates in between, so you can give an idea that this is going to be an empyema. So this is a rush of images, but these are not of practice. You need to, this is just a basic presentation, but it's a hands-on practice altogether. Thank you for your time.
Thank you, Dr. Munish. For the next session, the topic is on vascular access and DVT.
It's a suggestion to all the delegates. See, we are recording all of these things. So you have a big wide camera down below. So you can get all those recordings. My suggestion, just concentrate on the study talk that is going on. All these things will get in, we will share with you the videos also. So don't worry about it, you are not losing out on anything. Thank you.
For this session, we have with us Dr. Anupam Raj. She's a consultant in the Department of Anesthesiology and Critical Care, Apollo Indraprastha Hospitals, Delhi.
Good afternoon, everyone. So my topic for discussion today is on the vascular access and DVT scan. I believe that most of us are using ultrasound, and in fact, I would also like to believe that this is probably at least one place where you're learning how to handle the ultrasound, the needles, at least to begin with. So 75% of the patients in the ICU tend to have one or the other form of the vascular access. And because it is so common and everyone is doing it, there is a brief reminder of the things that we already know from the past. It is a standard of care. There is no reason why you should not be using ultrasound for the vascular access. It has shown to reduce the immediate complications in the form of the arterial punctures or hematomas or the pneumothorax. And the infectious complications, however, whether they are reduced or not is a context of debate, because many a times the strict aseptic precautions are not followed, which has shown over the RCTs that the use of ultrasound was related with the higher infection rate in the long term. So it is important, pertinent, absolutely, that you follow strict asepsis. The other thing that we already know is that there is an advantage of using a dynamic ultrasound technique over a static use of the ultrasounds. Now, infraclavicular area where we can access the axillary and the subclavian vein, they are the recommended first choice as per the latest guidelines. However, infraclavicular site still remains rarely used. Less than 30% of the regular users tend to use it, even though there is ultrasound which is available, because of the perception of higher chances of difficulty or the risk of pneumothorax. IGV and femoral vein are to be used when the infraclavicular site is either there is a problem or there is a contraindication. The international guidelines do not support the use of particularly the IGV over the femoral veins. They say that we can use both equally, and the only suggestions that they have is that in the patients with a higher BMI or the patients where the chances of having an access is more than 5 days, there you can prefer IGV over the femoral. So the tools that we are most likely going to use are a high frequency probe, which is 5 to 13 megahertz probe. If you do have a machine which has a color Doppler, that is definitely preferable. Having a sterile probe cover in the form of the probe covers which are available in the market, or using at least a glove over the probe, is absolutely important. Now the steps for the vascular access remain same. The way we have been trained over the years about the use of the Seldinger's technique. However, we need to incorporate when and where to use the ultrasound. So what they say is that first and foremost is to assess the target vessel that we are planning, then confirm the patency, then do the real-time guidance of the puncture of the vein, confirm the needle placement in the vein, then pass the guide wire and confirm the guide wire's position, and then pass the catheter. And once you have done that, you also need to confirm that your catheter is in the correct place. So a pre-procedural scan is very, very important, and there have been many protocols. One of the common is the rapid central vein assessment protocol, where you basically check the 6 major central veins around the neck in one go: internal jugular, supraclavicular, subclavian, infraclavicular, subclavian, and the axillary on both the sides. And you pick and choose whichever site is the best according to you. This is just an example of showing that what you can find if you are prepared. Let's say you're scrubbing up for an IGV, and after scrubbing you realize that you have reached a wrong place. So this was the picture that we got. We can see a nice artery here, and then there is a venous structure. On compression, we could see that the vein is basically completely non-collapsible, and there is a clear thrombus present. In the same patient, on further scanning, we did find the axillary vein which was available for the catheter insertion, and we definitely used it. Now, when we are doing the puncture of these vascular elements, it is important to understand how we are going to access them. So one is the either the long axis, oblique, or short axis. And when we are talking about the axis, we are literally talking about how the vessel of interest is placed with regard to the ultrasound beam. So if the vessel, you can see the whole vessel all along its length, it's basically the long axis, longitudinal axis. If you're cutting the vessel in the midpoint and you're seeing only a small circular dot, this is the short axis, and you might be cutting the vessel in an oblique angle, and that becomes your oblique axis. Now, this is just an example of IJV with the short axis, oblique axis, and long axis. The benefit of oblique, you can here easily see that the area that you can use would be higher. And both, unlike a longitudinal axis, both the artery and the vein are in the view. So, the chances of you accidentally puncturing the artery would be less. Now, when we are talking about the in-plane or out-of-plane techniques, what we are basically talking about is that how the needle is placed with regard to the ultrasound beam. So, when you can see the whole length of your needle under the ultrasound beam, that is your in-plane approach, and when you can only see it as a point, that's the out-of-plane. Now, after having understood our anatomy of the vessels around the neck, and how to use the ultrasound beam with regard to the axis, with regard to the vessel and of the needle, there can be innumerable approaches, and every single day a new and better approach has been devised. These green ones are the traditional approaches that are used to access the vessel: a short axis, out-of-plane approach for the IJV, and this particular infraclavicular, proximal, axillary, or subclavian in-plane approach are commonly used. While scanning, you can go down all the way to the lower end of the IJV, access it in plane or out of plane. You can also access the brachiocephalic or the subclavian in the supraclavicular area. And you can access these waves, the axillary and subclavian, by different combination and permutation based on how the patient's anatomy is and how easy it is for you to perform the vascular access. Now, this is the most common IJV access that people tend to do. So once you scan the neck of the patient, starting from the medial side, we have trachea, thyroid, carotid artery, IJV, and you can continue scanning the same IJV all the way down, all the way to see the brachiocephalic trunk. And we'll see that ergonomics is very important. For IJV, most likely you will be standing on the head end of the patient, and the machine will be on one side, and your everything has to be in one line. When you're going for a subclavian approach, here you're going to be standing on the same side that you're going to approach the vessel, on the same side, and the machine is going to be present on the opposite contralateral side of the patient so that you can have a clear view. And while scanning, the first space is, the easiest way to locate is, just keep the ultrasound probe under the clavicle, mid-clavicle, and you will see the subclavian vein and the artery, and just continue to follow it along. On the second side, you'll see the axillary vein and cephalic separate, because once the two join together, that's when the subclavian is formed. And then further going laterally, you will be able to find exclusively the axillary vein and artery. And like I said, that you can access them based on whichever way is convenient in that particular patient, depending upon how deep the vessel is, or how easy it is to access, either in plane or out of plane. Femoral vein cannulation, this is again one of the very common cannulation which is done. So important thing is that it's easy to keep the patient in a frog-leg position so that the vein becomes more superficial. And better to access the vessel when the artery is undivided, because there the angle to pass the guide wire, it will be easy for you to pass the guide wire. One word, after you have accessed the vessel, it is almost important to have a post-procedure scan. Now, there have been various studies which have clearly proven that it is easier and faster to find a complication by doing a post-procedure scan rather than waiting for 1 hour for your chest X-ray. So, in the post-procedure scan, you basically need to scan for the contralateral side. Contralateral side, if the your catheter tip has gone to the other side, or the subclavian. And you also need to perform a lung scan, like sir has just recently told you, to check for the pneumothorax. And then there is the rapid swirl sign, which will tell you that the catheter tip is in the vessel. So basically, the moment you give some fluid, there will be a rapid gush which will be seen. Most machines do have a cardiac probe, and after having learned your subxiphoid view, it is almost very, very easy to get this view. And lung sliding to rule out the pneumothorax. Once you have ruled out that the tip is exactly at the place where it is supposed to be, and it is in the venous system, and there's a swirl sign which is present and no pneumothorax, most of the people do not recommend that you need to have a chest X-ray done for your patient after that. Coming to the second part of my presentation, it's basically a DVT scan, and we're going to learn basically how to perform the DVT scan and how to confirm the presence of a thrombus by visualization, compression, and color Doppler. And what are the common false negatives when you are performing this exam? So now, the indications usually involve that, when you have a high-risk patient where you do suspect a DVT, or when you are having a collapse in the operation theater or in the ICU, you have done your echo, you know that there's a right heart strain pattern, and, you want to make sure that there is thrombus or not. Or if there's a patient with an unknown dyspnea and tachypnea, and you are suspecting that, the patient can have a DVT in pulmonary embolism. So this is a very basic picture which is showing, the three veins, the smaller veins, the peroneal, anterior and posterior tibial veins, which join together around the knee to form the popliteal vein, which continues in the thigh as a femoral vein, which is further joined by the deep femoral vein, and then finally the saphenous vein joins to make the common femoral vein. So it is important that all the places where the different veins are joining are the areas of turbulence, and those are the places where the chances of having a thrombus is going to be higher. So our scanning can basically, the scannings that have been discussed repeatedly are either a 2-point scan or a 3-point scan. Let's see what these points are. So basically, first point is right on top where you see the femoral artery and femoral vein, and femoral vein is joined by the greater saphenous vein. So this is the first point where the two different vessels are going to meet, and there is the area of turbulence, and there is a chance of having a DVT, a thrombus present in these area. Then further down, as we are coming in the leg, is the mid-thigh scans in mid-thigh, where the deep femoral vein joins the actual femoral vein, and then again there is a high chances of having area of turbulence and thus the thrombus, and then finally around the knee where the popliteal vein is present. So in a 2-point scan, you're only scanning, it's basically to reduce the time to help you with the diagnosis, which is the whole idea of having the POCUS. So basically in the 2-point scan, you will only check for the sphenofemoral junction and then the popliteal vein and confirm your diagnosis of whether there is a thrombus present or not. And in 3-point lung scan, you are going to check for the previous 2 points, sphenofemoral junction, popliteal vein, and also the mid-thigh scan. And if you do have time, you can feel free, go ahead, scan the whole femoral vein along the length of it. However, the various studies have shown the 2-point and the 3-point scans have similar sensitivity and specificity. So this is just a video where you can see that, this is the femoral vein at sphenofemoral junction, and there is a non-compression which is very clearly visible. Despite complete pressure, there is the vein isn't collapsing. And here, the vein isn't collapsing, and also there is a clear thrombus which is seen in this area of sphenofemoral junction. Now, when we are performing these scans, it is very important to have an idea about our common false negative and false positive. Like this very first video here, you can see that there's a femoral artery. there is a nice collapsing vein which is completely collapsible. However, there is a structure on the top which looks like a vein, and there seems to be a thrombus present. However, this isn't a vein, this is basically a lymph node. So this is a very common false negative when we are doing the scan, and then this is the whole picture. It looks like a non-compressible vascular structure. However, it's a Baker cyst which is present. So the common false negative that you need to be careful about includes apart from the lymph node and Baker node, are pseudoaneurysms, hematoma, and superficial thrombophlebitis. That is all for this. We'll see you at the stations.
Thank you, ma'am, for that very comprehensive overview. Before we start the session on fate, we have a small message from Dr. Preet Anand Singh from Changi General Hospital, Singapore. He was supposed to join us as a faculty for the workshop, but unfortunately hasn't been able to. He has recorded a message.
Anshuman, hi. Congratulations on the Yatharthcon. I'm sorry I'm not able to make it this time due to last minute changes in my schedule. I'm hoping I'm going to be there next year. Best wishes for the meeting that starts today, and enjoy. I know you've done the best with the program and the speakers, and I hope to see you next year. Bye.
For the next session on echocardiography, we have with us Dr. Bikash Ranjan Ray, Professor from the Department of Anesthesiology and Perioperative Medicine and Critical Care, AIIMS, New Delhi.
दोनों एक साथ ये वाला नहीं हो रहा, उसको बंद करो, उसके बगल पर एक डॉट आ रहा है, ये वाला हो रहा है। Okay, start. Good afternoon, everyone. So, myself is Vikas, and in next few minutes we'll be discussing how to do a point of care echocardiography. So, before starting, let me ask, how many of you are using at least a echo probe in your clinical practice? Please raise your hand. So, only one or two. So, those who are using may have some additional knowledge from this lecture, and those who are not using at least have the stimulus to go ahead and practice what they learn from the hands-on session and the lecture. So the first question arises, is echocardiography in ICU or in a perioperative setting makes sense? Is not it for the cardiologist? Why you are doing the thing which are not in our domain? So this is not like that. So their cardiology is something, there is a different domain, they do a comprehensive echocardiography, but when you talk about the point of care or focused echocardiography or PAID protocol, it is basically after your history taking and clinical examination, you have some certain doubts. To clear that, you do a echocardiography, and most of the time you expect the answer in a yes or no or binary fashion. Whether there is a cardiac tamponade, yes or no. Whether the LV function is okay, yes or no. Whether there is regional abnormality, yes or no. So to find out this answer, so you will do the echocardiography. So don't go and do other things. The cardiologists have a different thing to do a comprehensive echocardiography. When you talk about the focused echocardiography, we'll talk about certain views and certain questions to answer. So we'll see that. So what we'll do, discuss what is focused echography, why to do, what are the windows, what are the techniques, what are the different views, and certain pathology we'll discuss. A little bit about the Doppler's effect and the applications in the finding out hemodynamics and the FADE protocol that we'll discuss. So to start with, echocardiography, it has been found that even if you are a non-cardiologist, if you are well trained, the agreement between the cardiologist and the non-cardiologist, which is well trained, is nearly good. And most of the time, if you can find out up to 90% of cases the diagnosis correctly. So, point of control, as I defined, as I told you, is a focused goal-directed transthoracic echo performed by a patient's bedside by the treating physician to answer specific questions, mostly after the history taking and physical examination. There are different things we will not do. When you talk about focused echography, in the basic things, there is no measurements or no calculations. Most of the thing is by eyeballing. So, what is eyeballing? So, eyeballing something is like a visual memory. So, if you are standing beside the road and two vehicles passes by, you can definitely say which one is the fast one, which one is the slow one. So, similarly, if you scan a lot of normal hearts, whenever you put the probe in the abnormal heart, you can definitely find out what is there. So, that is basically a visual memory to find out that is eyeballing. In the beginning stage, we will only use eyeballing without any calculations, and that will be most of the time good enough. Then you can learn how to do the different calculations and the measurements. There are different advantages, will not go. This is the echo probe, also known as sectoral or phase direct probe. As you can see, there is a smaller footprint to accommodate in between the ribs. We'll not go into the physics details. We'll start with the scanning technique. So, position of the patient, most of the time in a perioperative setting or emergency or ICU to the supine patient, you will do the echocardiography. You can raise the left arm, which will abduct the left arm. That will increase the space in between the ribs. That will help sometimes. If you are not having a glued view, mostly for the apical and parasternal views, you can make the patient left lateral or left tilt. That will bring the heart to the closer to the heart, thoracic one, and I have a better thing. And also you can, for the subcostal views, you can flex the both knees, that will relax the abdominal muscle, and that will be helpful. Ergonomics, you do in both ways, will not go into details. So there basically you hold the probe in two ways. One is the standard underhand grip, in which is a pencil holding pattern. In certain views like subcostal, where you have to keep your probe parallel to the skin, you have a overhand grip. So focused echo, when you do a focused echo, you have certain views, and each view you try to find out answer to these questions. Is there any obvious pathology? What about the dimensions? What are the thickness of the chambers? What about the contractility? Is the biventricular contractility okay? What about the pericardium? What about the pleura? Is there any pathology involved? And everything should be clinically correlated. You don't do any intervention only on the echo finding. You have to correlate each and every finding with the echo findings. Also to find out any right ventricular strain. So basically, when you talk about the focused echo, this is basically three windows and 5 views. So the views are parasternal long axis view, parasternal short axis view, apical 4-chamber view, subcostal 4-chamber view, and subcostal IVC views. As you can see, these are the windows. This is the parasternal window. When you talk about parasternal, mostly it's the left parasternal window, apical window, and this is the subcostal. Because the heart is inside the thoracic cavity, to look into the heart, you require some windows. So these are the windows you have potentially. There are a lot of windows, much more windows, which are used by cardiologists. But to start with, we basically discuss these 3 windows and 5 views. So echo axis will not. The first thing, the parasternal long axis views. Long axis is, if your echo probe axis is along the long axis of the heart long axis is basically from the right shoulder to left hip. So if you align your echo probes in that direction, you have a long axis view. So this is the parasternal position. You put the probe here with the marker here oriented towards the right shoulder. And what you have a view is like something like that. If you put the thing is that this is the right V RV or RVOT, right ventricular outflow tract, interventricular septum, left LV is the left ventricle, this is the mitral valve, aortic LVOT, that is left ventricular outflow tract, aorta, and LA. So most of the time the echo is about recognition of the pattern. So this is the normal pattern you see, that is the parasternal long axis view, that is known as. As you can see here also, how the ultrasound beam is cutting the heart, and how this view is generated. So this is RV or RVOT, interventricular septum, LV, this is mitral valve, this is aortic valve, LVOT, aorta, this is LA, and this is the descending thoracic aorta. So this is normal, the parasternal long axis view. So mostly these are the view for use for pericardal effusion, contractility, even you can calculate the ejection fraction, measurement of LVOT diameter, etc. Now come to the short axis view. From the long axis, if you change your orientation marker 90 degree, now it is rather than right shoulder, now it was the left shoulder. So then It is a short axis view. Now the ultrasound beam is cutting the heart in a short axis. So as you can see, there is a term known as braid loafing. If you just like you cut the braid lobes, if you just tilt your probe in different direction, the ultrasound beam will cut the heart in different plane, and you have different views. You can have thousands of views, but most of the time, if the ultrasound beam is cutting at the level of the apex, it is an apical view, short axis view. If it is at the papillary muscles, it's papillary muscle view. If it is at the level of the mitral valve, it is a mitral valve view. It is at the level of the at the level of the aortic valve. This is known as aortic valve view or basal view. So, as just by tilting the probe, you can visualize whole of the left ventricle from the mitral valve to the apex. That is the importance of the braid loafing. How to do it, we will discuss at the level of the works hands-on session. So this is the first. This is known as the parasternal short axis or aortic view. When you discuss about the focused echo or basic FADE protocol, these views are not there. These are mainly in the extension view, extended FADE protocols. So these two views are not there in there, but we'll discuss something like that. You can see here, this is the, and if you label it, this is the aortic valve. You can see the RVOT, RA, LA, and pulmonary artery. So again, here you can find out how these views are produced, how the ultrasound beam is cutting the heart through this one, and how these views are produced. Again, from this view, if you just slightly tilt towards the apex of the heart, you have the next view, that is the parasternal long axis view, parasternal short axis view at the level of the mitral valve. Okay, again, here you can see the LV in a circular fashion, and the RV is mostly a crescentic cavity which hugs the LV like that. So this is the RV, this is the interventricular septum, this is the LV, and you can not the LV at the level of the mitral valve, and you can see the mitral valve in a fish mouth opening format. Again, these are the images how they are created. So this is the base of the LV. From here again you can tilt it toward the apex, and you can visualize whole of the LV. Next is the short axis view at the level of the papillary muscles. This is the view. Again, you can see the same thing. Now the valve is gone, and here you have the papillary muscles. RV is a crescentic sept hugging the LV, interventricular septum, and the LV. This is most commonly used view. You can find out different information from these views, like whether there is a hypovolemia. If these things are touching each other, that means there is a kissing papillary. That is, if clinically correlated, you can find out a suggestion of hypovolemia. This is again can be used for the finding out whether any regional wall motion abnormality is there or not. If with contraction, everything comes towards the center, and the thickness of the wall thickness increases. If something is not coming, moving in the opposite direction or not going, so there is maybe dyskinesia, dyskinesia, or hypokinesia. We'll discuss in the pathology sections. So again, you can find out whether there is RV strain or not. If there is RV is dilated, this will be much more straight line, and there is a D-sept ventricle with RV dilated. Again, suggestive of RV strain in acute condition may be suggestive of pulmonary embolism. So these are the information normally we have from this view, which is most commonly used. And lastly is the apex view. Here you can see the ultrasound beam is cutting at the level of the apex. Most of the time this view shows that there is some hypocontractility. You don't use apical view to comment about the contractility, but you can definitely find out whether any regional wall motion abnormality are there or not. Now apical 4-chamber view. You put the probe at the apex. Apex is normally midclavicular line, 4th, 5th interval space, just medial to that, but that is a variable thing that may be in a LVH, REH, RVH, maybe in different directions. So most of the time, you cardiologist, what they do, they put the hand, they try to palpate the apical beat, put the probe there. Otherwise, most of the time you start from the starting point, move laterally, medially, and try to have a better view. Then you adjust to have a better view. Here, the marker is towards the 2 o'clock or 3 o'clock position. What you have, as the name suggests, is a 4-chamber view. You have 4 chambers here. So this is the LV, this is the RV, this is the RA, LA, and the in between the valve. This is one of the basic view from most of the advanced echocardiography measurements, calculation, hemodynamic measurements. You start from the apical 4-chamber view. As you can see, you can have a lot of information from this view. You have all the 4 chambers. You have the interventricular septum. You have the valves. You can evaluate the valves. And you can have again regional motion abnormality, whether the chambers are dilated or not. So this can be thin. So then the question is how to differentiate which one is the LV and which one is the RV. So normally in a safe, the LV is the larger one, RV is around 2/3 of the LV, but these condition changes in the pathological conditions. So most of the time these are the different points, like the LV is much more globular, the apex is formed by the LV, the RV is a triangular, the movement of the RV is mostly in the longitudinal plane, where it is a much more complex plane. The mitral, the tricuspid valve, mitral valve is a bit upper, farther from the probe. So there are a lot of things. But if you are in a pathological conditions, if you are not able to find, you can find out most of the time there is a moderated band. This is a artifact or a papillary muscles which is mainly present in the RV. Otherwise, you can go for a 5-chamber view. Again, we'll discuss what is. Again, 5-chamber view is not a part of the basic FET protocol, but in advanced or extended protocol they are used. So we can use these. We'll not discuss this. So sorry. 5-chamber view. So we'll discuss the 5-chamber view. So the 5-chamber view is basically a misnomer. There is no fifth chamber. You know all that there is there are only 4 chambers are there. Okay. So there is no 5th chamber. However, if you just from the apical 4-chamber view, you just tilt the probe toward the supraclavicular notch. That is, you are aiming to look at the LVOT or the aorta, beginning of the aorta. So that is opened up like here. From the LV, that portion is opened up, and that is known as the LVOT, and that is known as the 5th chamber. So this is a misnomer or loosely used term. This is the apical 5-chamber view. As you can see, again the 4-chamber view, you just tilt the probe toward the supraclavicular notch or right shoulder. You have another thing opening. This is the LVOT, and this is the aortic valve, which is showing the aorta and the beginning of the aortic valve. And this view is known as the 5-chamber view. And as we go discuss, you can calculate the cardiac output and other things from these views. Again, how these views are created, you can see from these cross sections how the ultrasound beam is cutting here, and you are having these views. So next, coming the subcostal 4-chamber view. Here you put the probe in the subcostal region, and you are trying to look into the heart through the liver, through the left lobe of the liver. For this position, you most of the time use a supra hand, not like the normally pencil holding thing. You have a upper hand grip, and your probe should be parallel to the skin. And what you have a view is like that. Here how it probe the probe, and you have a view like this. If you see, if you level this one, this is the liver. You can see this is the first one is the right ventricle, left ventricle, right atrium, left atrium. It is same view, that is the apical 4-chamber view, just tilted in a clockwise manner. And first chamber is the RV. So this view is mostly used for, as you see in the FED protocol, in the FAST protocol, you can find out whether there is a pericardial effusion, pericardial tamponade or not, or any evaluation of the RV wall or RV, it is the better view. So in the 4-chamber view, if you tilt the probe again toward the cephalal direction and upward direction, what you have is a subcostal IVC view. Most of you must be using the IVC now. So you can see here, this is the IVC and this is the RA. And there is, as you can see from this ultrasound section, how the ultrasound beam is cutting and how only RA is visible. So this is the IVC, this is the RA, this is the confluence of the hepatic veins. There are 3 hepatic veins which combined and John, this is the confluence of the hepatic vein, whether only one is most of the time visible. This is a hepatic vein. Any measurement of the IVC you do here only, we'll discuss why and how. So this is the IVC view mostly used for any idea about whether there is a hypovolemia or not. If the both the walls are kissing, is again this is a kissing IVC. In a clinical context, everything has to be clinically correlated. If you put a probe in myself or yourself, you can have a IVC which is kissing each other, both the walls. That does not mean we require fluid. So in a clinical setting, when the person is a hypovolemia, there is a blood loss, there is tachycardia, there is something else, and you have a IVC, you again correlate that there is a fluid deficit and give this thing. We'll discuss from some few echo cases. So what is happening? Can anyone tell whose view is this one? This is a yes, parasternal long axis view. You ask in each view, you ask the same questions. Is the heart beating? Yes, is the heart beating? Is there any change in the dimensions? Most of the time there is slight enlargement, but it's a normal dimension. What about the pericardium? Here you can see some anechoic fluid. So most of the time it's a pericardial effusion. So pericardial tamponade is most of the time a clinical diagnosis. What you have is a pericardial effusion. You can have a tamponade physiology present, like in this one. Here you can see what is happening because of the increasing pressure. There is collapse, systemic collapse of the atrium and right side of the chambers in different phases of the cycle. So if those things are present, you can see it's a critical tamponade. Most of the time, or tamponade physiology is present. Most of the time, tamponade is a clinical diagnosis. So there are other features also we'll not discuss since. Can you summon? This one is the normal one, this is the abnormal. What is the difference? This is which view? Again, parasternal long axis view. So there is definitely dilated chambers and hypokinesia. So there is a global LV dysfunction, hardly contracting LV. This is again the same short axis view. This is at the level of papillary muscles. This is the normal one, the pathological, same patients, and you can see the same things. What is happening here? Normal heart. This is a parasternal short axis view at the level of the papillary muscles. What is happening here? So, yes, exactly. So, this portion is not coming towards the center, rather than moving in opposite direction. So, there is a regional one muscle anomaly, mostly this kinetic interventricular septum at that point. Okay. Again, this is the same person. You can have a 4-chamber view, apical 4-chamber view, as you can see. Rather than coming towards the center, this is moving towards the opposite direction. So, these are the things you can find out with the regional one muscle anomaly with basic point of Carrico. What is happening here? Parasternal long axis view at the level of the papillary muscles. Both are kissing. In a clinical kissing papillary are there, in a clinical scenario correlate, this is a suggestive hypovolemia. Same with the IVC, though both the IVC are touching each other. So these are the things you can find out here. Also setting like this. What is happening here? Can somebody say? This is which view? Subcostal view, 4-chamber view. Hai na? This is the RV, RA, LV, LA. So there is a mass, mostly you mass or whatever it is, there is a LA mass in this thing that you can find out. So will not again, as I have discussed, these are there is a right ventricular strain. It has become straight now a deceptive ventricle. In maybe in a clinical context, it may be suggestive pulmonary embolism. This is McConnell signs. As you can see, apex is moving, other portion is relatively not moving. This is the echocardiogram of some McConnell sign. One thing here you can, this is how to differentiate between pericardial and pleural effusion. The main thing is that the IVC, descending aorta. So if the fluid is above the descending aorta like here, so this is maybe a pericardial effusion, and if it is below that, it is a pleural effusion, and that can be clarified from this CT scan. As you see, this is the descending aorta. Anything above is pericardial, and if it is going below, it is a pleural fluid. Now, we will not discuss those things. Now coming to the FADE protocol. So the FADE protocol is basically a focused assessed transthoracic echo. Okay, so this is Eric Sloth, who is an anesthesiologist from maybe Sweden, and way back he have this protocol where he have certain views that can be used by the non-cardiologist, by any physician to find out these findings. They have the basic FADE views where you have only the subcostal 4-chamber view, apical 4-chamber view, parasternal long axis view, and parasternal short axis view at the papillary muscle. These are the basic 4 views and the pleural evaluation. And in a extended view, you have other views like the 2-chamber, apical 5-chamber, and other basal view and the mitral valve level views. So these are on the FADE protocols. Okay. So the thing is that always complete the FADE protocol. If you are doing, you have all the views before every reference rather than only one view. Okay. If you have some certain doubt, you go for the all views. So if you for the basic things, the take-home message is there is no rocket science. Okay. So if I put the probe, you put the probe, or the cardiologist put the probe, the image will be the same. It's the interpretation that matters, so you know how to interpret the image, that will be helpful. It's the adjunct to the standard examination. There is no replacement for the physical examination or the history taking. Eyeballing is most of the time accurate NM, and only when to improve the skill is by practice, and you always do echo because it can change management and change outcomes. So this is all about the basic echography. Now we go to the second part, how to apply this information. So those who are not using this, the first time you go from this place, always try to have a better view, because the only skill requirement for compared to the regional anesthesia that you will learn in the next 2 days, the same in the regional anesthesia you have 2 skills. One is how to have an image, how to have a hand-eye coordination. Here it is only one skill you have to acquire, how to have a good image. So if you have the image, everything further is only by calculation. You should know, it's like opening up a new mobile and finding out different applications. With near generation AI, everything is inbuilt. You have a view, save that, put the AI machine, they will calculate everything for you. So only practice thing is how to have a better view. Whatever you are going to learn in the next few minutes, these are the stimulus so that you can find out, but that should not be the first thing to learn. These things are very easy and you can calculate, or the AI software can calculate for you. So basically first we will learn certain different type of alters, Doppler's effect. We will not go into details how the Doppler effects are not. The only thing I want to emphasize is the Doppler equation. The Doppler equation, you can see you calculate the velocity. There is a cos theta cos angle in the denominator, and as you can see, that is the angle of insemination, that is the angle between the structures, the flowing structures or the blood vessels and the ultrasound, that is the angle of insemination, the theta. Okay, so and cos 0 is 1, then cos 90 is 0. So as you can find, if you want to measure the velocity, both the ultrasound and the flow should be in parallel or in the same axis. And if they are in the 90-degree direction, that is not possible. Okay, so that is the one thing. And so the thing is that if you want to measurement in an ultrasound, anything which is dimension, like 2D dimension or measurement thickness, that view is best where your ultrasound probe is perpendicular to the structure. When you have the velocity, that view is best where the ultrasound beam is parallel to the velocity of the structure. So with that, we'll mostly consider of the spectral Doppler. Spectral Doppler is only Doppler where you have a, I have 7 minutes. Okay. So, okay. So I have, spectral Doppler is one where you have a graphical representation of those things. So we'll not go those things. Basically, what you are focusing on the pulse wave Doppler, we'll discuss a bit. So ultrasound from hemodynamics, first of all, we'll discuss about how to quickly find out whether there is LV dysfunction or not. What are the RV functions? Is there a cardiac output? How to estimate the cardiac output? Whatever the volume status, and whatever preload upload dependence will system. LV system, there are a lot of ways you can find out the LV system dysfunction. But to start with, we will discuss only two things how to find out this dysfunction. Most of the time, what you do is a eyeballing. Eyeballing, as you discuss, you normally see the normal heart, and if it is 2 minutes, if it is changed, then that is different. That is, if you are normal heart, if anything abnormal is there, you can find out definitely that. Okay. So most of the time, everyone is obsessed with the ejection fraction, which is most of the time a useless thing to find out, because there are a lot of limitations of doing ejection fraction. But if you want to find out the LV functions, one simple way is to find out the EPSS or E point septal separation. So you put a probe here in the at the parasternal axis at the tip of the LV, at the tip of the mitral valve, and you have the M mode on, and you have a graph like this one. You measure this distance from the septum and this one. If it is less than 7, it is normal. We'll discuss how to do this in this hands-on stations. That is known as EPSS. Other thing is that you can find out the fractional area change or fractional shortening. And fractional shortening means the dimension in the diastole, dimension in the systole, and you have an equation from the diastole minus systole divided by diastole. And the twice is that of is known as the ejection fraction. So if we have those things, you can calculate. There are alternate like Simpson's method, which is most accurate, but that is most of the time from the cardiologist. You only want to have an estimate of the LV functions. If it is 45 or 47, it does not matter. Whether it is reduced or not, that is going to affect your management. Okay. RV functions compared to the LV, as you can see, RV is much more, the LV has a complex movement. It has a concentric movement, it's a longitudinal movement, it has a shortening movement. LV, 75% of the movement is longitudinal only. So here, if you are only looking at the longitudinal movement, that is known as the TAPC. You put your M mode at the tricuspid valve base, and you have a graph like this one. And you measure this distance. This is known as tricuspid annular plane systolic excursion, and from that you can find out the RV function accurately. So that is the only way you should know basically two things. Last one is the estimation of the cardiac output. As you can see, the cardiac output is a measurement of stroke volume and heart rate. So what you do is that you calculate the volume and the heart rate. Heart rate you have. So volume is area into distance. Okay. So area is whatever the LV is contracting is going through the LVOT. That is the left ventricular outflow tract. So that is the area you can calculate. You can calculate the LVOT area by measuring the diameter pi r square, and you have area. Whatever the distance, you don't have in distance, you can measure the velocity. So, but if you the velocity of the blood that is passing through the LVOT from the center to the periphery in the LVOT, and different time point from the starting to end are different. So what you do, you integrate that velocity over the time. And what you have is all the velocities in meter per second. The integration of the velocity is only distance. That is the distance you have. Okay. So you measure the LVOT diameter and you measure the VTI, that is the velocity time integral at the LVOT, both the same. But you do that in different plane. Okay, so you measure the diameter in LVOT in the parational long axis view, and the VTI in the 5-chamber view. Okay, and you have this formula. So 3-step approach: parational long axis view, measure the diameter, measure the calculate; 5-chamber view, measure the Doppler VTI, and both multiply those things, you have a cardiac output. Again, we can find out in the heart stations. We'll discuss later. Lastly, again, this is the IVC, you know, and you measure the IVC in different planes, and you can have the collapsibility, distensibility, and variability indexes. You measure it at the level of mostly at the level of the confluence of the hepatic vein, and you can calculate these things to find out whether the volume status of the person is volume responsive or not. So understanding the Doppler principle is important. LV systolic function, I-volume, or EPSS or ejection fraction in the beginning stage is okay. LV diastolic function not to discuss. You can estimate the cardiac output or have estimate of cardiac output from the calculation of the VTI, and you can IVC for have hemodynamic assessment. Any questions?
Thank you, Dr. Vikash. I think we will take the questions and further discussion in the hands-on session.
Thank you.
Thank you, sir. For the next session on spine, we have with us Dr. Manish Kohli. Sir is a senior consultant in the Department of Anesthesiology, Perioperative Medicine and Pain from Sir Gangaram Hospital, Delhi.
First of all, I would like to congratulate Dr. Anshuman sir and his team and Team Yatharth Hospital Management for organizing such a beautiful conference and emphasizing the role of ultrasonology in the perioperative period. The role of ultrasonology has been increasing day in and day out in the perioperative period, and I must congratulate Yatharthcon, or rather Anshuman Khan, for again emphasizing the role of ultrasound in anesthesiology. And greetings from Sir Gangaram Hospital. As rightly said by Dr. Chauhan sir, that the ultrasound is now the stethoscope for anesthesiologists. It has become our eye, it has become our ear. And nowadays, because day in and day out we are getting so much of patients of difficult spinals and epidurals, so I am increasing the horizon of ultrasound from the focus or from the tissues in which ultrasound can pass to the tissues through which ultrasound beam cannot pass. Okay. The basic limitation of ultrasound, the main limitation of ultrasound is that it cannot pass through bone, it cannot pass through air, it cannot pass through certain difficult high density structures. So whenever an ultrasound beam is incidented on bone or any hard structure, then it will only cast a shadow. And in order to get a space in between the two laminas, we really need to be shadow hunters. Understood? Before starting my discussion, I would just like to emphasize on a few basic concepts. Whenever an ultrasound beam is incidented on a round ball, then the ultrasound image that we will get from the reflective beam will be like this, like a straight line with slight curved structures. A few beams from the inside of the round ball can be projected on the outside of the ultrasound beam, and we can have some more shadows on the external areas. So the images may be quite diffuse. But now, if this ball is hollowed from inside, it is filled with air, then the image we will get will have a break in between. And when this hole is filled with some liquid, some tissues or something else, some material, then definitely the ultrasound beam will pass through the liquid or through that tissue, and it will be reflected back to the ultrasound probe and will give us an image. And so this is the basic principle of spine sonoanatomy. Spine sonoanatomy means to see the bony structures with the help of ultrasound. This is the typical vertebral body that we have, which has our transverse process, our spinous process, the facet joints, the lamina, and the vertebral body. And whenever these vertebral bodies will stack upon each other, then what we'll get? We'll get a lumbar vertebral system. Similarly, we'll get a thoracic vertebral system and a cervical vertebral system. Now the question is, how will we see this vertebral body or the vertebral system in ultrasound? Whenever an ultrasound beam is incidented on the vertebral body or any hard tissue, let us say the vertebral body, the first structure, the first shadow from the skin will be of the spinous process if the probe is kept in the midline. The second shadow will be of the lamina, slightly deeper to the skin, slightly deeper than the spinous process, and that will be approximately 1 to 2 centimeter from the midline. Similarly, the facet joints will cast a shadow slightly deeper to the laminar shadow at a distance of approximately 3 to 5 centimeters, and the transverse process will cast a shadow at a distance of approximately 5 to 6 centimeters from the midline. In the ultrasound beam, this vertebral body will cast a shadow. Let us see how. As I have mentioned, the spinous process in the midline will cast a shadow, a simple white line or a dark white line. Okay. And because of the reflected beams. And similarly, the facetal joints, the lamina, and other structures will cast a shadow slightly deeper to it. And similarly, slightly more deeper to it, the transverse process will also cast a shadow that will be reflected on the ultrasound image. In between the lamina, there will be the ligamentum flavum and the durum, the anterior and the posterior ligamentum flavum structures. So the posterior and the anterior ligamentum flavum dural complex will also cast a shadow. The overall image that will be something like this. The spinous process, the lamina with the facet joints, and the transverse process. So whenever we are viewing the ultrasound in the intertransverse process plane, the image that will get has a spinous process shadow, has a facetal joint shadow. This is mistaken as a spinous process shadow, but this is the shadow is actually of the posterior interspinous ligament. It is also hard, and this will cause a shadow. And whenever we will shift our probe to the intertransverse process plane or the laminar plane, then definitely we will not have the shadow of the transverse process, and similarly we will not have the shadow of the anterior or the posterior ligamentum flavum dural complex. Just to reiterate from a simple things that the simple ultrasound image is like the T2 image of the MRI. The only difference is that in the ultrasound image we can only see a section of the whole of the spine, whereas in the MRI we can see a hell lot of things. Now coming on to the sagittal plane, whenever a sagittal ultrasound beam is casted on the spine, the first shadow that we will get will be of the spinous process or the interspinous process plane. And this particular shadow in the midline will be present beneath the skin and the subcutaneous fascia, beneath the posterior longitudinal ligament, and this is called as the mountain sign. When will we shift our probe to the paramedian position or the parasagittal position, the shadows of definitely the facet joints, the spinous process, and the laminas will also come, and similarly the shadows of the anterior and the posterior ligamentum flavum dural complex. Our main interest is in this particular structure, the posterior ligamentum flavum dural complex, which we want to pierce to get a adequate spinal or a epidural block. Now coming on to the scanning techniques, first of all we'll go with the paramedian plane. We'll count the level of our L3 or the L4 vertebrae in the paramedian plane or the sagittal plane in the level A. the ultrasound beam is casted on the transverse processes in the paramedian plane, and the image that we will get will be like a trident. The transverse process will cast a dark shadow beneath it, and the image will be of a trident. We will shift our probe, slide our probe slightly to the midline in the line parallel to the interfacetal joint plane. The shadow that we will get will be of the camel hump sign. A number of humps will appear side by side. So this is called as the camel hump sign. In the same position, if we will tilt our probe towards the midline, that is towards the lamina, which is also called as the paramedian sagittal oblique plane, then we will get the horse head sign. In the horse head sign, we can see there are humps. Oh, table laga diya beech mein yaar. There are humps, but beneath the humps there is a shadow. There is a line of the posterior ligamentum flavum dural complex that we want to pierce to get an adequate spinal and the epidural block. Definitely, these patients are quite obese, and we'll use a curvilinear probe for the adequate vision. In the old days, there is a sacralization and the lumbalization of the vertebra. So first of all, we'll scan in the paramedian position so that we can mark our level, whether this is the L2, L3 level or the L3, L4 level. After marking the L2 or the L3 level in the paramedian plane, we shift our probe to the midline, towards the midline, and at that particular point, we'll tilt our probe to the transverse direction so that we can also scan the intertransverse process line and the interlaminar line. At this particular point, definitely we have the ligamentum flavum dural complex and this shadow. What we can do, we can memorize that at this point we have the ligamentum flavum dural complex, and we can insert the needle directly, or else we can hit the lamina and we can walk over the lamina to get the ligamentum flavum dural complex. Sitting position is ideal for all these things, and again I will iterate that look for the trident sign, look for the camel hump sign, and look for the horse sign. We are not interested in the camel, we are interested in the horses. Okay. The chronic pain physicians are interested in the camel, but we are interested in the horses right now. For this particular obese patient, what I will suggest that after doing the sagittal and the transverse scan, and after visualization of the anterior ligamentum flavum dural complex, which appears as the most wide space in between the lamina, we should mark the placement of our probe. We should compensate for the width of the probe. The probe is approximately 1 to 2 centimeter width, and it has some length. But the beam of the ultrasound is like a credit card, so it is in the center. So we should look into the center. For this, what we can do, can I take some more time? 2 minutes, 2 to 3 minutes. Okay. We'll point at the midline of the probes, superior to inferior and lateral to lateral. We'll join the two lines, and we'll hit the midline. We'll remove the probe, and we will hit the spine in the center. Okay. Another thing is there that we will teach in the our scanning sessions. Similarly, for the kyphoscoliosis, we look for the ligamentum flavum dural complexes. We'll draw the midline and we'll angulate our needle so that we can hit in the midline. Some tips and tricks that at first we should practice on the normal and simple spinals, and use 2 hands. All other tips and tricks definitely will teach you in the station. There is another real-time technique which really requires a super expertise, but it is also seen that in the real-time techniques there are more number of needle passes and the success rate is also less. Nowadays there are many signs, the rabbit sign and the shamrod sign, and there is utter confusion what it is. It is nothing but just we have to see the vertebral body from the sides. We should see for the transverse process and the vertebral body. This is also, and this particular angle is called as the thumbs up sign. The same particular angle is called as the shamrod sign, and the same particular angle is called as the rabbit sign. Okay, and this is our favorite, which is the caudal epidural. We want to look for the sacral cornus, and we want to hit between the sacral cornus just to pierce the ligament. And some wise gentlemen also given this sign, the frog sign. We are chronic pain physicians. We are quite interested in the thoracic vertebral bodies. And it is said that the thoracic spine, we have the flag swan sign. But I think this is more like a Kung Fu Panda. This is a Kung Fu Panda sign according to me. But don't get indulges in the sign. Just look for this wise young lady who has bring laurels to our country. One eye is closed just to concentrate on a particular length and on a particular light so that she can hit the probe. Similarly, we should look for our target. We should look for the interspaces between the vertebral bodies. We should look for the lamina, and we should get our good spinal epidural. And I must say that we should emphasize our ultrasound knowledge over our traditional landmark approaches. We are not doing something new. We are just applying our ultrasound knowledge to the traditional landmark approaches. And a big thank you. Thanks for the time, madam.
Thank you, sir. So that brings us to the end of the lecture session. We are getting ready to start up the stations. Yes.
Actually, the plan was that this was planned to be the delegate, the volunteer scanning station and the food station. There is a big, huge, wonderful terrace on the left side, and we had planned to use it for the conference. But probably the rain god had other plans, and we had to get it inside. So now we have food, volunteer scanning, everything here. On Sunday, because we have 10 stations and Sundays is a relatively rush-free day, so the RA stations will be in the B1 level. At the basement 1, that is the OPD level, that is huge, so that is 35 rooms, so everyone will get a room. Here we will start putting in the stretchers and we'll start connecting the connection so that we will have the hands-on session. Because the number of stations are less, so what we have done is that we have added the ONSD and airway in a single station. So that leaves, even there are 8 talks, there are 7 stations. FATE has 2 stations, ONSD and airway is in the same single station. So suppose there are 7 person in single group, so you can mention, you can see in your delegate card, it will be mentioning what color and for what date it will be mentioning. Does it have a number in date? It has a date, so you know your group. So you go to that group. ONSD and airway, only one group will go, even though there are 2 stretchers. And rest of the parts, rest of the things, rest people will move together. As Dr. Preet could not join, so we have one faculty from our hospital, only 2 faculty basically, they will help you out in the FATE. So Dr. Vikas will take 1 FATE and the other person will take 1 FATE. So give us 2 minutes and we'll just, as we align all those things, and we can go ahead with the hands-on session. Thank you. Dr. Shiva Shamungam is there. He comes from Pondicherry. He took a cab from Pondicherry to Chennai, then a flight from Chennai to Delhi. Then in this rain, the flight got delayed half an hour. Then 2.5 hour travel time from Delhi airport to the Radisson hotel here. And that too, when he's running 102 fever with antibiotic and paracetamol. So it takes a lot of effort for people who are coming from that far off to attend, to come and teach you things. He could have jolly well said, no, I cannot come. Preet could not come. He had booked the tickets. His tickets got cancelled. But he had to cancel the ticket because he couldn't get the leaves, and that amount, everything was gone to drain because he couldn't come. He was very sad. We have a group of the faculty, and he was always up with an energetic enthusiasm. My only idea is that gathering all these big names here as faculty is not easy. They need to keep themselves free. And with that running fever, he has come just to teach. So yesterday, the plan with Shiva was that today night he had to reach at 12 midnight. And then he had to attend tomorrow's live session. He said it is not possible for me, so he booked another ticket so that he lands at 4. But then the rain god had different plans. So it's, as an organizing part team, our team has taken every possible option, arrangement, so that people are not, don't have any problem to come and attend the thing. Now, plan for tomorrow is that 8 to 9 we have a breakfast. 9 o'clock onwards, we will have simultaneously live demonstration. One will be live demonstration, that will be masterclass, that will be done from this auditorium only. So it will be managed by 4 faculty, very seasoned faculty, Dr. Anil Sharma, Dr. Divesh Arora, Dr. Manish Kohli, and Dr. Devesh Bhoi. So our plan is we will start a master scan on a volunteer. And after that, we'll swap the image with a block that will be done in the live demonstration, that will be done in the OT. So you need to align all those cases so that you also see what is happening. My purpose of doing a masterclass is that when you start giving a block, you put an interscalene or a supraclavicular or infra or a costo, then axillary and individual. But you do not know how to take the probe from interscalene level till individual level. Sliding the probe is very important. What I want is that, because most of the people here are enthusiastic, because if you come from that far off, then they're enthusiastic about this thing. My idea is that when you see a image in the ultrasound, you should be able to diagnose and pinpoint what are the structures that are visible. That is very important. Just seeing a nerve is not important. That AI can do for you. You should know all possible routes. If there is a vessel coming, how you need to bypass that vessel. Tomorrow, time permitting, we will show you upper trunk blocks, and that too in outer plane blocks. We are trying to show you maximum possible blocks in live, but we are concentrating mostly on 3 parts. One is brachial plexus, one is anterior aspect of thigh, and one is posterior aspect of thigh. Devesh Bhoi, Dr. Shishir Agarwal, all these people, they are today in Yatharthcon, Lucknow. They'll be traveling tonight with all those flights and bad weather, and tomorrow they will be here. So everybody, Dr. Anil, Dr. Anupam, Dr. Chetan, they have swapped their duties so that they are doing night call so that they can attend the session. Suppose Dr. Anupam is doing tonight, tomorrow she will be doing night call. So tomorrow she will not be there in the gala dinner, but she will be there in the sessions and the workstation. So my idea is that the faculty who comes here, they put in a lot of effort to come and teach you. So my always interest is that you should always try to grab as much as possible from them, because this is the way we have done it. The delegate faculty ratio is very nice. Hardly you get 3 or 4 people there in a single group. So we will start master scan here, and we will swap with the live demonstration there. We will try to finish it till 1. 1 to 1:30 we will have lunch. I again tell, we will start at 1:30. We will not start at 1:31. So you have to finish your lunch by 1:30. Post 1:30, we will be deliberating on talks and panel discussion. The talks are good. The panel discussions are amazing. Panel discussion is basically you have lot many queries. Now when you start seeing blocks, you see, okay, this is that, this is that, this is that. What block where and why? So that query will be interested in panel discussion. The reason I kept the talks 15 minutes and panel discussion 30 minutes is that because the delegates, it should not be one-way communication. It should be two-way thing. You have some query, you will ask you can also put questions, all those questions, what you need to do. Once the panel discussions are done, we have got a very fantastic quiz session. So it's if you can answer the quiz, you get a prize. It's as simple as that one. Good question sets. So that will show how much you know about the RA and all those things. And this will be followed by a gala dinner with cocktail at Radisson. Let me tell you, it won't take a lot of time. Tomorrow I won't tell you that you do not go to Radisson, because it is hardly 2 kilometers from here, less than 5 minutes. So it is absolutely near to this thing. But today, if you think even of going now, it is very difficult because completely it's chock-a-block. Dr. Vikas had to leave at 5:10. He left at, I think, 6:20 because the driver got stuck. So if you go now also, you cannot reach the destination. You will be sitting in the car. It's like sitting in a rocking chair, you're moving, but you're not going forward. So that's the whole idea. We'll have a short inauguration ceremony, and I understand that after this long day, no one is interested to have a big thing, but as a group, as a department, we have thought something. So we will be having some interesting talks and discussions. So we will do that. In 30 minutes it will be done. You can have your high tea and we can leave. Anyone who has any query, then you can let me, anyone has any query? Tomorrow your transportation from here to Radisson will manage. From here to Radisson, we'll see how you will be will go there. From there, you can book your cabs to go back, or whatever is the conveyance we want to do that. Fine? Thank you.